Hi, y'all, and welcome back to Professor Trulo's Concepts for Nurses series. And in this episode, we will be discussing transient ischemic attacks and stroke. As usual, sources will be from Iggy's Medical Surgical Nursing, 9th edition, and Soul, the Introduction to Critical Care Nursing, 7th edition. But first, let us talk about transient ischemic attacks, or TIAs. These are temporary neurologic dysfunctions resulting from a brief interruption in cerebral blood flow. This is due to cerebral vasospasm or systemic arterial hypertension. Usually last a few minutes to fewer than 24 hours, and symptoms usually resolve in 30 to 60 minutes. However, it is not unusual for the symptoms to resolve before the patient arrives at the hospital. Multiple TIAs indicate a high stroke risk. Warning signs that cause transient focal neurologic dysfunction resulting from a brief interruption in cerebral blood flow, possibly resulting from cerebral vasospasm or systemic arterial hypertension, are also causes for alarm. And this is because the TIA should be considered a warning sign. So look for that transient focal neurologic dysfunction, which will help to pinpoint where the interruption is because of the brief interruption in cerebral blood flow. As far as providing treatment for these patients, stabilize the patient as necessary, complete a thorough neurological assessment, including but not limited to labs, computerized tomography, electrocardiogram. When you're discharged, the patient is usually placed on an anticoagulant therapy, such as Plavix. You should know that patients who are older than 65 years and those patients with diabetes or who have symptoms lasting longer than 10 minutes or those with persistent motor or speech difficulties are often admitted to the acute care center. And the fear is that this will develop into a true stroke, an acute stroke or a brain attack. This is the third leading cause of death in the United States. It is the most frequent cause of adult disabilities, and it is the leading cause of long-term care. There are more than 700,000 new strokes that occur each year, and the cost is estimated at $57 billion annually. And this is despite the fact that most of the risk factors for stroke are controllable, including things such as hypertension. There are more than 4 million people in the United States who are stroke survivors, and people who have had strokes have a 10 to 20 times increase in the risk of having a subsequent stroke. A stroke or a brain attack is a sudden loss of brain functioning resulting from a disruption in the blood supply to part of the brain. It can be classified as ischemic or hemorrhagic. An ischemic is an interruption in blood flow to the brain because of a thrombus or embolus. So it's usually caused by a constricting of the blood vessel due to a buildup of plaque or by a clot that is broken away from a vessel and is lodged into one of the arteries of the brain. This blocks the blood supply, and it is often related to atherosclerosis, and it may occur again. While as a hemorrhagic is bleeding within or around the brain from causes such as a ruptured aneurysm or an arteriovenous malformation or AVM. This bleeding into the brain tissue can be slow or fast and is often related to hypertension. Hemorrhagic strokes result from ruptured aneurysms and AVMs. In either case, the brain is unable to store oxygen or glucose. The brain, recall, requires a constant flow of both in order to properly function. So the causes and the types of stroke are because of a change in normal blood supply to the brain. Again, this is caused by things such as hypertension or a malformation. And the types can be ischemic, thrombic, embolic, or hemorrhagic. Risk factors for stroke include advanced age, heredity. Although the incidence in the genders is equal, women are more likely to die because of the stroke. Other factors include a family history of stroke, being of African American, Hispanic, American Indian, or Asian Indians, because they all have a higher incidence of stroke than Caucasian. Other risk factors include a history of TIAs and a history of atrial flutter or atrial fibrillation. Modifiable risk factors for stroke include heart disease, diabetes, high cholesterol levels, excessive alcohol consumption, obesity, physical inactivity, poor diet, and drug use, particularly stimulating drugs. It is very important that the healthcare team differentiate the different types of stroke because that will dictate the type of therapy, that is, interventions, to be begun. So, therefore, imaging tests such as CT scan or MRI are highly valuable in determining whether there is the presence of blood into the brain or if there is negative for blood in the brain. Further, Doppler flow studies, particularly of the carotid arteries, can indicate risk factors that would be associated with stroke. Further, ultrasound imaging can do the same thing. The most common kind of stroke encountered is the ischemic stroke, which accounts for about 85% of all strokes. It usually results from large artery atherosclerosis, which is the result of stenosis in the large arteries of the head and neck, caused by cholesterol plaque or a thrombus superimposed on that plaque. Blood flow may be significantly reduced, known as stenosis, causing ischemia, or occluded completely, causing a stroke. Hypertension, diabetes, smoking, obesity, and hyperlipidemia are also risk factors for this type of stroke. Cardioembolic states occur because of low flow states or stasis of blood within the cardiac chambers, which may result in blood clot formation. The embolism occurs when a blood clot or plaque fractures, breaks off, and travels to the brain. The most common causes of cardioembolic stroke are atrial fibrillation, rheumatic heart disease, acute myocardial infarction, endocarditis, mitral valve stenosis, and prosthetic heart valves. It is important for the team to remember to treat the underlying cardiac problem as well as the neurological problem. Small vessel occlusive diseases can cause lacunar strokes. These are usually because of chronic hypertension, hyperlipidemia, obesity, and diabetes. These disease states cause a lipid material to coat the small cerebral arteries within the deep structures of the brain. This process leads to a thickening of the arterial walls, decreased blood flow, and ultimately a stroke. The most common locations of these strokes are the basal ganglia, the suborbital white matter, the thalamus, the cerebellum, and the brainstem. The recurrence rate for these types of strokes is 10 to 20 times when compared with other types of stroke. This type of stroke causes not only physical impairment, but also cognitive impairment, such as vascular dementia. Patients can have pure motor, pure sensory, or both motor and sensory features of this type of stroke. On the other hand, hemorrhagic stroke accounts for 15% of all strokes, usually as a result of a severe hypertensive crisis. The elevated blood pressure leads to changes within the arterial wall that leaves it likely to rupture. Hemorrhagic strokes occur more often with sudden, dramatic blood pressure elevations, such as those seen with things like cocaine abuse. So, a ruptured cerebral aneurysm with subarachnoid hemorrhage is a common source of a hemorrhagic stroke. You should know that an aneurysm is an abnormal ballooning or blister along a normal artery. An aneurysm rupture causes bleeding into the subarachnoid space, the ventricles, and or the intracerebral tissue. At this time, a vasospasm occurs. A vasospasm is a sudden and periodic constriction of a cerebral artery. Blood flow to areas distal of this site being supplied by that artery have markedly diminished flow. This leads to further cerebral ischemia and infarction and further neurologic dysfunction. So the AVM is an uncommon abnormality that occurs during embryonic development. It is a tangle or spaghetti-like mass of malformed, thin-walled, dilated vessels. And because these vessels are dilated and thin-walled, they may and do eventually rupture. So the sudden spike of blood pressure seen in abuse of things like amphetamines and cocaine are likely to precede this rupture and then hemorrhage. There are symptoms that are considered classic signs of stroke. These include hemiparesis or weakness, which is a sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. Slurred speech and confusion, that is, sudden confusion, trouble speaking or understanding. Visual disturbances, such as sudden trouble seeing in one or both of the eyes. Dizziness, nausea, vomiting, and a headache, the worst headache of the life. That is, sudden trouble walking, complaints of dizziness, lack of balance and coordination, and that headache having no known cause. You should remember that time equals neurons, so the patient must be evaluated within 10 minutes of the arrival to the emergency department. Include in this assessment your ABCs, a thorough neurological assessment. Try to obtain, to the best of your ability, a baseline of pre-stroke level of consciousness, mentation, and cognition, and a history, including, very necessary, when the onset of symptoms occurred. In other words, the last time seen normal. The team must quickly differentiate between the different types of stroke as to see whether this is a hemorrhagic or occlusive type of stroke, because that leads the intervention. For that reason, an emergent CT is ordered. The time of onset of symptoms must be established. And there's other diagnostic tests that are done to rule out other causes. For instance, obtaining a blood glucose level, obtaining a 12-lead EKG to rule out the neurological changes that are being caused by cardiovascular problems, and MRI or CT. If an ischemic stroke is indicated, then the treatment for ischemic stroke must be implemented. If there is a radiological intervention available, the patient should head for that department. However, for most facilities, this means clot-busting drugs, and specifically IV or systemic thrombolytic therapy, using a retrovase transplasminogen activator, or RT-TPA, which is commonly known as TPA. You do this by establishing eligibility criteria using the National Institute of Health Stroke Scale, or the NIHSS. The thrombolysis is accomplished through the arteries, that is intra-arterial, and is only effective if given within 3 hours of the onset or the last seen normal sign. However, newer criteria is pushing this up to include up to 4.5 or even 6 hours, depending on the situation. You should always remember these patients are at increased risk for bleeding. So, cognitive changes on the neurological assessment include aphasia, alexia, and agraphia. Motor changes include hemiplegia, hemiparesis, hypotonia, flaccid paralysis, and hypertonia. Sensory changes include agnosia, apraxia, neglect syndrome, ptosis, retinal ischemia causing a brief episode of blindness, and even hemianoxia. The nurse should perform cranial nerve assessment and should perform a thorough cardiovascular assessment. That does conclude this episode of the Neurological series. Please stay tuned as we're going to discuss some of the complications associated with stroke. We'll see you then.